I'm Dr. Allan Perel, and this is Conversations in Medicine. This program brings cutting-edge medical topics to the Staten Island, New York City, and tri-state area. Tonight marks the beginning of our second season. Myself and all the people involved and the staff who put together this show want to thank you for your wonderful and positive responses, and I want to thank everyone who works together to make the show possible. Today's topic is on medical marijuana. We're going to talk about cannabis tonight. We're going to talk about the use of medical marijuana in medical illnesses. There's been a lot of restrictions about marijuana use around the country, and different states have different rules. And we try to get the evidence-based aspect of this. And for that, we have a wonderful guest, a good friend of mine, Dr. Jack D'Angelo. He's CMO, Chief Medical Officer of Sativa Medical, and he's a physiatrist. And he's really very expert in this whole process of marijuana, getting it out to people, what the indications are. And as you know, there's only about 250 doctors right now in all of New York State who are certified.
And that's part of the challenge. So let's talk about why even mention medical cannabis? What brought about this whole change in our approach? And so much of this was driven by parents on a grassroots level, looking for treatment for their kids that was otherwise unavailable, and anecdotally had heard stories or experiences where this helped them. And so that's really what spurred the conversation. Flash forward 4 years later, and we're 29 states, including the District of Columbia, that has medical cannabis programs. And just to draw a distinction, I don't like to call it medical marijuana, even though that happens over and over and over again, and you hear that, mostly because marijuana is really a slang term that was associated to it, and cannabis is really the actual name of the medicine and was in the pharmacopoeia, which is our list of drugs that pharmacists have available, until the 1940s, and then was removed. So it's an interesting topic about how it's come back into play. What separates medical cannabis from recreational cannabis is chiefly the standardization. So we have a process, let's face it, it's like any other medicine, right? You go, a doctor has to be able to reliably recommend to someone this will work. And how we treat medicines is we like to know that we take a specific dose at a certain time, it will have a specific result, and that's kind of predictable. So with cannabis, on the medical side, it's really the standardization process that we embark on that separates one company from another company or one brand from another brand. But all along, it's to create a product that's the same every time someone takes it.
Let's talk about New York State. I mean, we're in New York right now. What's the New York State law with regard to medical cannabis? So
in New York State, we have a law called the Compassionate Care Act that was actually put forward by Senator Savino. And what that did was identified 6 to 8 diagnoses that cannabis could be used for. I kind of have weird feelings about that because I don't necessarily like the health department telling us how to use a medication that way. They don't do it with all the other medications that we use. But in this scenario, they did, and in lots of states, they have done this. So for instance, it includes things like HIV, cancer treatment, nausea, vomiting, Parkinson's, multiple sclerosis, ALS, epilepsy, neuropathies, and now most recently chronic pain. They give themselves a great deal of flexibility. The health department is now looking at 4 or 5 other additional diagnoses that they are looking to see what intervention there has been, what data there is, and whether or not it's safe to kind of expand it to those diagnoses.
We like to use the term evidence-based, and both of us are physicians, and I'm a neurologist. I deal a lot with multiple sclerosis, Parkinson's disease, people with Alzheimer's disease, ALS, things that are in the indications. And actually, a majority of the indications are actually in the neurological field. The evidence that, and we've talked about this, and I've researched it again as a dispenser or someone who gives the prescription out, the evidence is actually there for many of these disorders. Tell us a little bit, how does cannabis actually work? And you mentioned a story before about in pediatrics.
Sure.
These were kids with a very intractable seizures called Dravet syndrome. And cannabis was shown in those kids to actually have tremendous benefit. And that's what brought this uproar or swelling of support from the moms and dads who had children affected
Right.
by this disorder that really didn't have any other effective treatments. So maybe if we could talk a little bit about
Sure.
evidence-based medicine, what kind of things are available or out there that we know these
So,
medicines
you
work?
know, sometimes there is a lag between common knowledge and our behavior as an organized medical system. And I think cannabis is one of those issues. There have been over 20,000 articles published in PubMed, which is kind of a reliable source about cannabis, that really talk about the role of cannabis in different things. In the United States, we've had very limited, what we would call large-scale, double-blind studies that give us confidence in terms of an evidence-based medicine discussion because of the legal issue surrounding cannabis. So even though now it's legal perhaps in a state, it is still federally illegal and it's still treated as a controlled substance by the state. So you are limited into what studies could actually be done. The National Institutes of Health has always done studies on cannabis, but it was really only side effect studies. They never looked for efficacy. Now they're kind of expanding that profile a bit, but one of the issues is the efficacy based on a study really depends on the product you're testing, and all products are perhaps a bit different. So that's something that as we move forward will get further defined, but we are now looking at them kind of expanding that profile on the studies that they're looking at, and therefore authorizing people to do these particular things. We do have a rich amount of data available though, right? Because we have Colorado, California, Oregon, Washington State looking at these things and have been doing studies and collecting data. And so there are certain areas that we know have great promise. Inflammatory bowel disease is one of those examples. But why does it work? In our body, there's systems, and we know that nerves communicate with each other by secreting little chemical messengers that kind of jump from one nerve to the next and kind of start a signal. In our body, there's something called the endocannabinoid system. That is kind of like a filtering mechanism. And believe it or not, while we talk about it, and it's been known for a while, there are only 2 medical schools in the whole country that even spend any time at all teaching young doctors about this, which is a little bit unfortunate because I believe it's a doctor's mission to know what his patients are being exposed to. And so, but what we know is that there's a chemical in the body, a messenger called amantamide. Amantamide has the exact same structure as THC. So we know that the body has a system in place to metabolize, digest, and use THC. Move the conversation a little forward. We've now identified that within the plant, there are, besides THC, which is the common thing that everyone knows, there's about 80 to 100 other cannabinoids. And these are very potent natural anti-inflammatories, chemical transmitters, assisters in the way the body has other metabolic symptoms in terms of managing and fine-tuning. So the question is, how do you create that, and what makes one product different than another?
So let me ask you in a little
Yeah.
different way. If somebody, for our audience, if someone has one disorder, say multiple sclerosis versus
Correct.
someone who might have cancer, when I prescribe this product, I know they don't get the same amount of CBD, which we could talk about, and THC, different active agents. How do they figure it out?
All right. So we believe very strongly in something called the entourage effect. And what that is, what sets cannabis apart from any other prescription that we write, or even from the prescription versions of THC that are already available, is that we're harnessing the whole plant. So that's all of the terpenes, which are kind of the flavor or aromatic aspects of a plant, as well as the cannabidiols and the THC. Then what we do in kind of a lab environment is we are extracting them from the plant. There are 2 principal types of extractions. There's what we call a CO2 extraction mechanism and an alcohol extraction mechanism. And basically what that is you're basically filtering the plant down into its smaller components. THC, CBDs, and the different CBDs, and the terpenes. Then what you're allowed to do is you bring it back all together and you make a particular oil or product that suits your purpose. In New York State, we have only oils, tinctures, and capsules.
Tell us what
available.
a tincture is, because that's what we've always been mentioning now, that the only product available in New York is a tincture.
Right.
Or an oil.
So it's a tincture or an oil. The tincture obviously is an alcohol-based, really allowing very rapid absorption through the mucosa in the mouth or under the tongue. And so the oils are something that you can swallow. We do not have edibles in New York, and there's particular reasons why we don't. And we don't have whole plant in New York.
Which is smoking.
Right.
And they have that in New Jersey. And
Correct.
in states right nearby, we have that. Do you think there's a difference in the benefit of the agents? I have patients who live in New Jersey, and they come to me and they say that they've been prescribed by New Jersey physicians smoking marijuana,
Right.
cannabis. And what I tell them is that in New York, I could only give them a prescription for the tincture or the oil, as we
Right.
mentioned a few moments ago. They try both. They have different ideas about benefit. And again, it's very difficult in any one individual to know whether it's going to work
Sure.
better or not. In your expertise, do you think, is there one more preferable to the other?
So I think the New York model is an outstanding model. Why? What separates New York from many of the other states, including New Jersey, is we actually have pharmacists in the dispensaries. So these are people, think about it, this is a medical-based product, right? So if you're going in to use it, you're probably taking other medications. There are other issues that in terms of your own general health that may be an issue. So the pharmacist kind of acts as the person to really guide you. There are not a lot of drug interactions with cannabis, but a very common interaction is with something like Protonix or Nexium, things that many people are taking for gastroesophageal reflux disease, and there can be some interaction there. So in other states, like in New Jersey, they don't have pharmacists in the dispensaries. They have someone called a bud tender. And a bud tender is just what you think it is. It's someone who very often is wearing a tie-dye t-shirt and giving advice on this without any real medical background. So we really kind of like the high road and moving in that direction. Even though someone is getting oils, that doesn't mean that the oils can't be vaporized and inhaled through like an electronic pen type device. So my personal feeling is, yes, there is a role for the true flower, all right?
Smoking.
Yes, but it makes it much harder to standardize. Mm-hmm. And if what we're trying to do is establish standardization, we have to be able to reproduce the dose so that it's the same dose every single time, and that there's no question about what you're getting.
So the New York model makes it really just like going to a pharmacy and getting
Correct.
medicine.
Correct.
It's in a bottle. It looks the same each time you go there. Very different than smoking, which can have different substances in it.
Exactly.
Even though the state does provide it, they try to keep
exactly
it as proper as
you know.
can.
And there's a lot that goes into the process, right? We're growing a plant, so at any point in time, there's a lot of regulation in terms of making sure that the plant is healthy, that the plant doesn't have any molds or funguses or things like that. Anything that can happen as a supermarket in the vegetable section can happen with the plants you're growing. So there's lots of regulation along the way to assure that the product is pure and clean and healthy.
If your doctor, and I think we said there are a few hundred doctors in New York that have the ability to prescribe it, and that basically means going through a course and taking a short test and being aware of the medicine. So if I prescribe to someone or you prescribe to someone, how do they actually get the medicine?
All right. So let's make a point of clarification. We like to say that the doctor is giving a recommendation, not really a prescription, because you're not generally really prescribing it, right? So when you see the patient who's being certified, that means you're looking at them as their physician and saying they fulfill the diagnostic criteria. This might be something that might help them. And the diagnostic criteria set by the health department is, do they fall into one of these ranges? Then you're going online and with the health department, you're getting them a number. They're taking that information. They have to go online and also register with the health department with that number. And they also can specify a caregiver that will help them get the medication or go to the place to get the medication if they can't get it. Then they will get a card from the state. With that card, then they can go to the dispensary. What you're giving them is kind of a very generalized recommendation about what to use, whether it's a high THC product, low CBD product, whether it's a high CBD product, low THC. And how do you decide that? Really depends on what their disease state is and what you're trying to manage. If I'm managing someone who has extremes of pain, I might tend to go with a higher THC product than if I'm managing someone who has spasticity, because I know that those patients tend to respond to a lower THC product and a higher CBD product.
So the ratios are very important.
Correct. And we all know anecdotal stories, right, for recreational cannabis use of people who have smoked or used marijuana and then develop extreme paranoia or are hiding under a desk and all this stuff.
Yes.
And that's because very high THC without CBD creates that anxiety. CBD is a very potent anti-anxiety agent. So the CBD mellows out the THC. So, however, on the street, why people are using recreational cannabis is for that high THC content. They're not really looking at it from the point of view, this is really good for me, and I want all those potent anti-inflammatories that I can get out of the CBDs.
I understand.
So that sets it different in the marketplace that way.
So let's go into a little bit more about medical marijuana and cannabis use. Tell me about the relationship between recreational, maybe actually we would say medical cannabis and opioid use.
Okay.
There's been a whole epidemic of opioid overuse. We've had tragically so many young people dying, and even middle-aged and older people dying of heroin overdoses.
Right.
There's been a large restriction on physicians being able to prescribe narcotics in the way of pills. So there's been a shift into getting high-potency agents such as heroin.
Right.
Is there any treatment modalities that this helps with, or any ideas that people are using less opioids because of the cannabis? Or does recreational marijuana escalate to using those medicines?
And that's a good question, right? Because on one hand, we were all brought up believing that recreational cannabis was some kind of gateway drug to stronger drug use. I would say this, that over the last 4 or 5 years, in terms of my involvement in this process on both a state level and a federal level, in terms of conversations, I'm very happy the process has taken a very slow time. I think if we had taken such a slow time with the use of expansion of opioids, we wouldn't have the problem we have. But you know, you and I both know that in part that was a little bit political, how that happened. We were the victims of that, and everything we were taught, our whole educational experience as physicians, was questioned and thrown out the window.
So what you're getting at is that we used to use a term called pain is the 5th vital sign.
Correct.
After your heart rate, blood pressure, temperature, and things like that.
Right, but as physicians, we knew it really wasn't a vital sign because pain is different than your blood pressure, your heart rate, and your temperature. There's a subjective nature to pain. So we're doing that assessment based on showing you a smiley face or an angry face and asking you where your pain falls. But for everybody, that's different. But that led us down this road, and this road of having a conversation about opioids, whether or not addiction is the same as tolerance, whether or not our patients are going to get addicted when they're using it for a general medical purpose. And the truth of the matter is, now we can look back over the last 10 years and say they do, and we made some mistakes. With cannabis, what we have noticed is that there is pretty quickly a 40 to 60% reduction in the use of opioids when we take a patient who's on opioids and add cannabis to their treatment protocol. That could be the difference between taking someone off of almost lethal respiratory doses of opioids into more normal doses, and therefore then being easier to wean them off the rest of the way. So that is striking. There is a reason why that happens at a receptor level where it competes for an opioid receptor. So there is a reason why it happens. But the truth of the matter is it's very helpful. Same thing we're seeing with things like PTSD, post-traumatic stress disorder, that cannabis has been really helpful in that environment. Also, these are patients who tend to be quite limited in function because of their post-traumatic stress disorder, whether that is a military relationship, whether it's everyday life relationship, it all comes in all shapes and sizes.
Post 9/11, as we see.
Correct. And really been very helpful at helping people to maybe avoid some of the other drugs that people are addicted to manage their anxiety and stress disorders, like Xanax and alprazolam and Ativan. And as we all know, those drugs are almost as addictive or more addictive than opioids, and even harder to get patients off of.
Yes, and many times people who are on those medicines have to go into inpatient rehabilitation.
Correct.
To get detoxified.
That's
They're
correct.
so potent, some of those agents. And actually, what's so interesting, as you know, is the shorter the action of a medicine, the more frequently you have to take it,
Right.
the higher the risk for addiction is.
Right, because your body just gets primed for it, right? It's probably no different than how if we eat a lot of donuts, we want more donuts. And that's just the bottom line. There's something about those pleasure centers in our brain that when they're stimulated, whether it's by drugs or food or whatever, we just want more of it.
Now, we both take care of patients. And the idea that we talked about different disorders, but even when we talk about newer indications like chronic pain, post-traumatic stress disorder, how do you position it? And this is where I think it's so interesting that so few physicians, and we said only a few hundred doctors in all of New York,
Right.
actually dispense or have the prescription or recommendation, what word you said before. The concept is if you don't prescribe or you don't recommend this agent, you're not going to use it in your armamentarium. In your philosophy, and I'll tell you with multiple sclerosis at our center, we're using cannabis much more as a first-line, second-line drug for people who have spasticity.
And that's exactly how it should be used, because the truth is, it really works. Right. And it has, it's a much safer profile than anything else. You know, cannabis has a very high safety window. It's very hard.
What does that mean?
It's very hard to get a lethal dose of cannabis, as opposed to lots of other drugs. And so that being the case, there's a huge safety window in terms of how you prescribe. But more importantly than that, what you're going to see is that this has been a time where patients have gotten a little bit more vocal about what they want. Mm-hmm. And they know the side effects of their other medicines. We're not necessarily taking them, right? As the physicians, you come to us with a problem, we're trying to solve your problem. But we don't know what it feels like to take all those medicines because we don't have to take them. And there is an effect, a cumulative effect that happens from those medicines that makes people feel tired, listless, and non-functional. I think cannabis changes that conversation.
Logistically, I have patients on Staten Island. My practice is around here. Tell me, where do you actually go with, where's your dispensary? Where are the dispensaries in New York City?
So up until very recently, we've had 5 licensed companies in New York State that each company was able to own 4 dispensaries. That was just increased, I think, by another 5 licenses. So over the course of the next year, those licenses will be rolled out. The state tells you where you can open up your dispensaries. The state tells you the price that you can charge. So in every dispensary, it will be the same.
Just as an aside, is any of this covered by insurance?
None of it's covered by insurance. And probably won't be for some time, although insurance does have to cover in New York State the doctor evaluation. Mm-hmm. So the visit to do it, the insurance has to cover.
And I'll actually interrupt you about what is the cost of it for a patient?
Listen, when insurance covers it, right, it's going to be the cost of an office visit. Mm-hmm. All right. However, we code that depending on the patient that we're seeing and the complexity of that patient. There are a lot of people who are charging for that visit separately on the basis of the fact that there is a processing period of time that they have to do, right? They have to go onto the internet. They have to log in the patient's information. They have to get paperwork drawn up. It's got to be put into their chart. So there's stuff that people need to do. And I would say that those fees run anywhere from $100 to $250. Then you pay a fee to the state for your card, which is about $50. There are hardship issues and other things like that where you can get an exemption for that fee. And then with that card, you are going to one of the dispensaries. The closest ones to us right now, there's one in Manhattan, there's one in Queens that really end up being our closest dispensaries. Those are run by two different companies. And you would then go to the dispensary. And now also in New York State this year, moving forward, we should have delivery service enacted so that once you are a registered member of that dispensary, they can then deliver the product to you.
Interesting. So where are we going with cannabis, with medical cannabis? You mentioned more indications, post-traumatic stress, chronic pain, cancer patients, multiple sclerosis patients, a plethora of neurological disorders. Where do you think 5 years from now we're going to be with medical cannabis?
If I look 5 years from now, where I think it could make the most significant impact is in nursing homes.
Tell me about that.
All right. Think about the chief problem we have with people as they age or as they're sick is A, they lose their appetite. B, they may get more agitated and anxious. And what cannabis does, obviously, is it stimulates your appetite and it creates a better mood for the patient without the risks and the side effects of many of the medicines we use right now to accomplish the same thing. So Israel is a big proponent of this. If you go online and Google nursing homes in Israel with the use of cannabis, it's fascinating. They do a lot of work. There's a lot of work being done with dementia and cannabis, but mostly this is quality of life conversations for that patient group and how the safety profile really improves dramatically when they move in that direction.
And that's why, as you probably know, you go to many of the skilled nursing facilities around the city. I go to many of the skilled nursing facilities. And I wouldn't have thought of that as a place where cannabis would make such a big impact.
Yes.
But when you think about it, it is. And I think there's a lot of jokes that people would say about it. And that's why we try to bring this program out, not to laugh.
Correct.
Not to think we're going to have some 90-year-old person taking marijuana and doing
Correct.
that.
In fact, most of medicinal marijuana, and this is an important thing to keep striking home, most of medicinal marijuana is not about getting stoned or high. Mm-hmm. It's not about that. It's about that potency of the anti-inflammatory effects, the anti-anxiety effects, the anti-pain effects that we're really trying to grasp.
So most people actually don't get high with it. And
Correct.
It's really for a medical indication like others. Jack, thank you. Dr. D'Angelo, it's been a pleasure. We learned so much about medical cannabis. What a cutting-edge issue. And hopefully we'll be able to bring this to our patients and give them the best of care, whether it's cannabis or other things.
Definitely. And Allan, thanks for the opportunity, because I think the more people are educated, the better off they'll be.
And I really want to thank our public officials, our elected officials, for really moving this along and really through their tremendous effort getting this done, like Senator Savino.
Definitely.
Thank you all and good night.